Welcome back, ladies and gentlemen, to the Doc Talk podcast. This is Dr. Ray J. Got my boy, Dr. MJ. What's up, man? Hey,
Not much, man.
You good?
Enjoying it, man.
Awesome.
I'm actually really liking this whole podcast, getting to talk, catch up to you. We've been working so much, we don't get to talk.
Really?
Yeah.
Yeah?
I saw you playing basketball the other day.
That's fine.
That's pretty good.
I have, bro. But you know what's the problem?
What?
The problem is that my knee's been killing me.
Bro, you're young. What do you mean your knees are killing you?
I know. And I think I got a little bit of osteoarthritis. I'm not going to lie.
Is that the topic today?
You know what?
Let's talk about arthritis.
Arthritis? Is
Let's
that what we're doing?
Man. Tell me about arthritis.
Pain. Joint pain. Joint pain typically. I think I'm a little young, though, to be honest with you. I don't think I have arthritis. I might have heard it when I was playing, but I don't think I actually have osteoarthritis. But they actually say that typically osteoarthritis happens in, over the age of 45, wear and tear a little bit, joint distress, inflammation, etc. Have you ever suffered from arthritis at all?
No, arthritis not really, but like you said, we're too young, bro, and I'm too athletic.
Are you saying you're young?
Come on, Doc.
Okay,
Somebody like me doesn't get arthritis.
Stop showing off. You're showing off right now a little bit. I'm trying. I'm working. I'm trying to be like you.
Nah, I'm skinny, bro.
Really? Oh, hold on. You said you're skinny. What does that mean? So does that mean I'm fat?
No. Like out of the two brothers.
So you're the skinnier brother with hair.
It's not what I said.
No. You said you're the skinnier brother. You're skinny.
That's why you're wearing a hat.
So what is it? Oh, okay. So
no. We're not talking about the bald. We're not talking about bald.
Okay.
We're talking about arthritis today.
You started.
I know, but we're not talking about bald today. We're talking about arthritis.
Okay, go ahead. Fine. Well, then talk about arthritis.
Let's talk about it. Okay. So
osteoarthritis?
Yeah. There's a difference between osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis is much worse than osteoarthritis, but they're both painful.
Fine.
One of the most common things I see in my patients is complaint of knee pain, shoulder pain, elbow pain. All of these, most of the time, more commonly is osteoarthritis. Mm-hmm. But if you want to be tested for rheumatoid arthritis, that's a whole different pathway to get tested.
So we're focused more on osteoarthritis. Osteoarthritis. So basically, osteo means bone.
Okay.
Arth means the joint, and any itis just means inflammation. Okay, but it doesn't necessarily mean that you have inflammatory disease, because inflammatory disease will be more of rheumatoid arthritis, lupus, etc. But osteoarthritis could have inflammation in the actual joint. I'm sure you get, because I get tons of osteoarthritis patients.
Let's say a patient comes in. I have knee pain. What do you do? Like, give me the steps that you do for the patient.
First things first is I ask if they had any trauma or falls or whatnot. And if they haven't any, most likely it's an inflammatory joint. Okay. So I typically tell them to ice the joint. Okay.
Rice, right?
Rest it. Ice it. Yep.
Compression. And elevate. Let's go. I like that. Okay. I learned that in
You got any arthritis here? No, arthritis. You're good. You're still young. It's
That's
good.
How we do it, man.
Nice biceps.
So tell me about it. So if somebody has arthritis, comes to you, complains of pain, right?
Yep.
What do you tell them to do?
First thing I tell them, honestly, is to rest it. Because a lot of these patients will say during activity that it's painful, or they wake up with severe pain. Or I have patients that predict the weather. Cold weather definitely exacerbates a lot of
pain, people up north, and they always complain when the weather changes. When it gets cold, all of a sudden their joint pain gets worse.
Exactly.
And honestly, it's a tough thing to deal with, especially with patients that have been, having this joint pain for a long time, have gained weight.
Yep.
Because honestly, gaining weight with arthritis is very difficult. Because just imagine, right? You have your bones. The more weight you put on the bones, the more pain you're going to have.
I agree.
That's why I always tell patients, work on the weight loss, get some exercise in, loosen up the joints around it. Because one of the biggest issues I deal with arthritis is that patients start compensating, right? So they start off, I have right knee pain. Mm-hmm. If they don't get that right knee pain taken care of, all of a sudden they got left knee pain, then right hip pain, then left. That's why I would say take care of it, because once you start compensating, you start developing pain in other joints also.
I agree.
And so, I like sports, and that's one of the biggest things that I always talk about. Stretching, making sure that before you go out there, before you do anything, know what your limits are too.
And muscle strengthening for sure. So I think we have to look at risk factors, right? Typically, the majority of patients with osteoarthritis are 45 years or older, all right? Obese, and athletes, a lot of them get it also. So
from the trauma, from all that.
You look at the patients who have, you look at their occupation in general, what they did for a living before they retired, if that's the case, if they're retired. You're going to get arthritis in patients who are a lot more active, construction workers, athletes, people who.
So it doesn't have to be somebody just out of shape, because actually the athletes are putting more trauma to the joints.
Versus the patients who are more sedentary, they will probably have lesser symptoms than patients that are a lot more active. So if you have a 68-year-old male patient
Mhm.
who did construction for a living and they come in and complaining of left knee pain, this is their first time they complain about it. What is your first step? What do you do?
We can order an X-ray
Okay.
just to see how bad the joints are.
But does the X-ray actually help to treat the patient? Does it make a difference?
No, but at least it would guide us on how bad it is, because some people have bone on bone.
Okay, so
And-
let's say you
and
got a knee X-ray.
Most of the patients that have came to me are already at a point where they've tried Tylenol, gotten
Mm-hmm.
an X-ray, and then now we're at a point where we're doing like joint injecections.
Okay.
Okay.
But isn't that usually?
Do you
so
do that in the office? Joint
I
injections?
do. I do
Okay.
a lot of joint injections in the office, but I typically leave it as a last resort.
Yeah.
So first thing I do is that I sit, same thing we talked about earlier. I sit, rest it, etc. Take some Tylenol. So they took some Tylenol. They've been taking Tylenol, and the pain has not subsided. They come back to see you after a few months, and doc, my left knee's still killing me. Now what?
I go into things like physical therapy also.
Okay, so
And the reason I do physical therapy so that they don't compensate, like what we talked about earlier.
perfect.
Fix that knee, because if you keep avoiding it, then you're going to start having pain somewhere else.
Okay, so
And you also don't want, this is one of the biggest things I always tell, because we mainly work with geriatric patients, right?
yeah, we do.
And getting a knee replacement or a shoulder replacement or hip replacement at a young age, because of the joints don't last a long time, you might have to do it twice.
Yeah,
So I
agree.
try to avoid it and get the knee or the pain, wherever it is, stabilized with physical therapy, whatever it is,
Mhm.
because if it keeps getting worse and worse and you end up bone on bone and now they're talking about replacements, that's not where you want to be.
It's steps. It's steps. First thing you got to do is the patient overweight. Lose the weight.
Lose the weight.
Is
So
the
you can get
Tylenol
that-
not working?
Yeah.
Well, okay, let's try something a little bit stronger. Now, of course, I like to avoid NSAIDs in patients with kidney issues, stomach issues, etc.
Bleeding
We
issues,
understand.
yeah.
We got that. We got to take
And
that
make
into
sure you
consideration.
talk to your primary care. I mean, this is
course.
what we're talking about
Of course.
broad. Like,
Yeah.
make sure you discuss this with your primary care.
I agree. So we've tried Tylenol. We've tried the weight loss. The patient has struggles to lose the weight. Got it. What's our next step?
So we've done the Tylenol, we've done the weight loss,
Yep.
we've done physical therapy.
Yep, we've done physical therapy.
Okay,
And
and it's not getting any better.
It's not getting any better. Would you consider an injection at this point?
When we get to a point where we are considering joint injections,
Mhm.
my options are: does this person continue to gain weight
Mhm.
and not get better, and then start having affected other joints? Then I do it just to make sure that. But I make a deal with my patients.
Yeah.
Before I give you that injection, we need to have a game plan. So
Yeah.
we get the injection. What's your game plan? What are you exercising? What did you sign up into the gym? Do you got a personal trainer? Have you started physical therapy? These are things you have to discuss. You can't just give them the
I
joint.
get it, dude, but you got to take these things into consideration because the majority of patients are not going to end up doing that, to be honest. They
Yeah.
might increase their activity or do some muscle strengthening. But in reality, if the patients had a knee joint injection and you gave them all these recommendations and it didn't work, what are you going to end up doing?
And so we can talk about what you can do, but also I want to talk about what not to do.
Mhm.
One of the biggest issues we have, I'm in Newport Richie,
Yeah.
huge issues with opioids.
Yeah.
So
it is.
And this is what I tell my patients why I don't like opioids. I'll give you an example.
Tell me.
You have back surgery,
Yeah.
right?
Okay.
Somebody that's on opioids versus somebody that's not on opioids, right?
Mhm.
The person that's on opioids, he's numb. He doesn't
Yeah.
feel it. So if I have back pain and I go down to reach and pull something, I can injure my back and not feel it because I'm on the opioids and I'm numb from the pain. And you actually start causing more damage. If you put two patients, one that goes on opioid, one that doesn't, the one that's not on opioids usually does better long-term than the one that's on opioids.
I agree with you, but
And we
okay,
have
let's
so many-
let's make sure that the patients know what opioids are. Medications like Percocet, medications like
Hydrocodone,
Vicodin,
yeah.
hydrocodone, Norco, acetaminophen. All of these are opioid medications. So, if the patients have tried opioids, have tried knee injections, how often do you inject your patients?
I try not to do it more than twice a year.
Okay.
I really try, even like once a year. Never go under 3 months.
Yeah.
Now,
yeah.
there are doctors that are doing it every 3 months. I prefer to avoid the 3 months.
What about gel injections?
Gel injection, like the halogen
Like the
injections.
halogens or the
Usually,
Suparts.
if the steroid hasn't worked,
Yeah.
then we could jump into like a halogen or
Okay.
like a gel type of injection. But you got to qualify for that too.
But how do you qualify for that type of injection? I mean, because I heard that. Okay, so I personally, in my office, I give 3 gel injections. I can up to
Once
certain
a week,
point,
right?
Once a
Yeah.
week, of course, and then I can go up to a point for a five total from the series. I could do 5 injections. How if I've injected my patients with steroids and I've injected my patients with gel injections, and 3 weeks later they call my office and say, you know what, I'm still having pain.
Are they bone on bone? Are they at that point where it's
So
that
they
bad?
had so they say they had an
But
X-ray.
that goes
and
back.
it's moderate to severe osteoarthritis.
But that's what goes back. we keep talking about treatment,
Yeah.
but we need to start working on prevention also. So let's discuss with the patients. Let's prevent them from getting to a point where they're bone on bone. Okay. Come into the office. I'm right there in Newport Richie, 7366 Cedar Lane, Newport Richie. Come see me. I'll make sure it's taken care of for you. Where are you at, AJ?
I am at 92 West Cypress Boulevard in Homosassa, Florida. Your body will not take care of you if you don't take care of your body. Simple as
100%.
that.
100%.
Okay, take care of yourselves.
And we're going to do
strengthen
more
your muscles.
topics of this. We'll discuss it more. It's hard to get it in 10 minutes.
I think osteoarthritis in general is such a broad topic that there's so many factors that play.
But we just
into
wanted
it,
to give them an idea because some patients are stuck.
Okay.
And so, you
So
know,
you think patients should come see you or see me?
I'm a little bit better at injections than you.
Really?
Yeah.
Honestly, you think so?
I don't know.
I think we should definitely check that out.
We'll see.
That's good. That's fine. All right.
Anyways, man.
So, ladies and gentlemen, thank you so much, and Dr. AJ, Dr. MJ, and we'll see you guys next time. Thanks.